OsteoBites is a weekly osteosarcoma webinar and podcast presented by MIB Agents. This week, we're talking about upfront surgery for osteosarcoma, a clinical trial concept, with our guests Matteo Trucco MD of Cleveland Clinic and David Loeb MD PhD of Children's Hospital at Montefiore. Our panelist is Amanda Levine of the Facebook group Bone Cancer Support. I'm your host, Anne Graham. Welcome to OsteoBites. This is an exciting edition, and we hope you have your snacks ready. It is, after all, OsteoBites. I brought my Pepperidge Farm Brussels cookies, but I ate them because they were delicious, and I couldn't wait. I hope your snacks are good too. My name is Anne Graham. I'm an osteosarcoma survivor. I started MIB Agents in 2012 with the mission to make it better for kids with osteosarcoma. Our mission continues today with direct patient and family support through our many programs and by bringing together the physician, researcher, and patient community to work together toward kinder treatments. Our annual Osteosarcoma Factor Conference is a part of that, and now OsteoBites is an ongoing part of making it better. Super excited about our topic today. Can't wait to get started. Please welcome our presenters. We have Dr. Trucco and Dr. Loeb, and of course, Amanda. And I'll have them introduce themselves, starting with you, Dr. Trucco.
Hi, I'm Matteo Trucco. I'm a pediatric oncologist and director of pediatric clinical trials at the Cleveland Clinic, and I've been working with Anne Graham and MIB Agents to help with the Factor Conference and given a couple of these OsteoBites already. And I trained under David Loeb, who can introduce himself.
Hi, I'm David Loeb. I'm the Chief of Pediatric Hematology and Oncology at the Children's Hospital at Montefiore in the Bronx and Professor of Pediatrics at Albert Einstein College of Medicine. I've been in New York for 3 years. Before that, I was at Johns Hopkins forever, during which time Matteo worked closely with me. And my story.
I'm Amanda. I am the administrator of the OS group on Facebook. I became involved in the group about 10 years ago after I was a 23-year survivor of OS when I was diagnosed with breast cancer because I didn't know of anyone else having a second cancer, which now I am very well versed. And a couple of years ago, I was diagnosed with ALS, which is why my speech is a little messed up. So ask me what 100 times if you don't understand me.
Thanks, Amanda. Dr. Trucco?
Okay, so as often happens when you put a bunch of oncologists together, we start talking and coming up with ideas. And this concept came up back in November when Dave Loeb and Scott Bornstein, who's at Vanderbilt, but couldn't join us today because it's his clinic right now. We were at a conference here in Cleveland, and we started talking about what we can do to try to change things up a little bit and maybe learn a little bit more about osteosarcoma. And as we kind of dreamt up this clinical trial idea, we, realized that it's not just us oncologists that need to buy into a clinical trial and believe in it, but also our orthopedic surgeon colleagues and ultimately also the patients that would go on these clinical trials and participate. And so with the Factor Conference, MIB, and now with OsteoBites, we thought what a great way to actually actively, get the osteosarcoma community involved in seeing whether or not these ideas are worth moving forward. So I have a few slides just to kind of go over the concept that we're proposing, and then Dave can chime in on any of the slides, and we can then we can then open it up to questions. Excellent. So again, this was Scott Bornstein kind of started this idea in discussions with Dave, and I kind of just tagged along. And so I think I've shown this graph before. It's the outcomes of the last big clinical trial that we did in osteosarcoma. And the two solid lines are MAP, which we all hate, but it's a necessary evil, and whether adding ifosfamide etoposide to MAP increased outcomes for patients with actually poor necrosis to the upfront chemo. And as you can see, kind of going out 5-6 years, the overall survival rate, which is what the y-axis is about 60 to 70% for localized disease. The broken up lines are the same two treatment arms, but for metastatic disease. And as you can see, the metastatic disease patients do significantly worse, with outcomes around 20-25%. And what this Kaplan-Meier plot shows is that pretty much adding ifosfamide etoposide didn't really improve the outcome over the outcomes of MAP alone for either patient. That study took 10 years to do, and we're basically where we were before that. Nothing major has really come to the forefront to see if adding it to MAP would help. So in this scenario, while we know that metastatic patients do worse than localized patients, we don't know who those 60-70% who are going to be cured with localized disease are going to be. We don't know who the 25% that are going to be cured who have metastatic disease are going to be, and we don't know the ones that are going to progress. Part of that is because we don't understand the fundamental biology of osteosarcoma very well. And right now, the prognostic signs that we have are whether you have metastatic disease or not, and whether it's in the bones or in the lungs. A little bit where your tumor is, whether it's in the extremities, those do a little bit better than if it's, in your pelvis, for example. There's some subtypes of osteosarcoma, largely that doesn't change a whole heck of a lot in how we treat it and the outcomes. Again, we know plenty of patients with the ones that are supposed to be slightly worse who do well, and the ones that are supposed to be slightly better who do badly. They're just very imprecise. And as we discussed on prior OsteoBites, this whole tumor necrosis thing after the first 10 weeks of chemo, yes, better necrosis is what we all hope for, but there's plenty of patients who have great necrosis and they go on to relapse, and there's plenty of patients who had poor necrosis and fortunately they do well, and vice versa. So these prognostic signs are extremely imprecise. And so when a new patient comes to us, we have no way to predict who is going to do well or not, other than some of these very imprecise metrics. So currently, this is how we approach osteosarcoma. You come in, you get a biopsy, you get 10 weeks of chemo, and then you get surgery to remove the local tumor. Let's say it's in your leg. So these biopsies are teeny tiny. They look like pencil leads. They're extremely small core needle biopsies. Sometimes we do what are called open biopsies, where a surgeon actually takes you to the OR and takes a chunk of tumor. So there's a little bit more, but it's still not a huge amount of tissue. After the 10 weeks of surgery, you get the whole tumor taken out, and when the pathologist looks at it under the microscope, a lot of it is necrotic. Hopefully, because the chemo is working, but there's only so much you can do with even a huge tumor, but if it's all dead, there's not much you can actually learn from it and study from. After that, in the trial that I mentioned earlier, you got randomized whether you had good response or not to different therapies. Turns out adding any drugs didn't accomplish anything, so ultimately you're stuck with more MAP after the surgery. That's where we are. That's where we've been for the last 20, 30 years. So what we're proposing is, what if we take the surgery and move it up front? That way you get this huge chunk of tumor. It's fresh, it's viable, and potentially we could study it to learn more about the basic biology of a new osteosarcoma. We would lose information about good or poor response because there's no tumor there to necessarily measure. And we would do your full 29 weeks of chemotherapy as would be done anyway. And so we'd kind of be flying blind, but we'd kind of be doing the 29 weeks anyway, because that's what we do and that's what we know to be the best for osteosarcoma in this day and age. And this would provide a platform for additional things down the road. So one of the things that prompted us to kind of look at it this way is a relatively new concept of how to look at cancer. Right now we think of cancer as a mutated cell that's like a zombie and just divides uncontrollably, and chemotherapy kills cells that divide quickly, and so that's how chemo works. But some mathematicians and evolutionary biologists, especially down at Moffitt that we work with, kind of pose the question of maybe we got to look at the cells, the cancer cells, more as kind of organisms, the way evolution might affect organisms. And that these cancer cells are competing with each other. And within that tumor, there's actually subpopulations of cells that behave differently and have different characteristics, in large part due to their environment, just like animals do. And there's something about that mixture and how kind of evolution is happening within that tumor, so that the cells that are best adapted to that environment are the ones that survive, and the ones that eventually lead to metastases and are able to evade chemotherapy and the other treatments we do, as opposed to a kind of mindless just clones of the same cancer cell over and over again, as we had historically thought. So if we view cancer as an invasive species, our goal is to make it extinct, meaning curing the patient by killing off this invasive species. And so potentially moving the surgery up front gives us helps in this regard, but also gives us a platform to study more approaches like that. So if you accept this concept, which we are actually studying in rhabdomyosarcoma, we'll have a clinical trial coming out next few months. If we accept this concept, then there's a few things we can do. We need to base our future treatments on what we know about evolution and making species extinct. How did the dinosaurs become extinct? How did the passenger pigeon or the dodo bird or any species we know is extinct or becoming extinct? We know kind of what's caused that globally, and maybe we can apply that to treating cancer. An important concept is this thing of minimally viable population. If you reduce the population of a species down to a specific number, that population cannot survive as a species. So with passenger pigeons, which used to like block out the sun, there were so many of them, the minimal viable population was pretty high. In some other populations that maybe don't require such a bulky, a large population, that minimal viable population might be lower. And I'll show you some pictures to kind of represent it in cancer, but we need to identify what that minimal viable population in cancer is. Maybe it's just one cell, so we have to get a less than one cell to try to cure it. And so there's different ways, again, based on evolutionary principles, of how to drive a tumor below that minimal viable population. One is an augmented first strike, so basically a bigger gun, a bigger asteroid to wipe out the dinosaurs. So bigger, potentially more precise chemotherapy. A second concept is kind of taking more of the extinction models that worked for more recent species, where you have deforestation, you have pollution, you have hunting, you have all these various different things that act in succession to eradicate a population. and we could apply concepts like that to cancer. So that's a second strike after first strike. And then maintenance, which is this kind of slow grind to weed out the species that slowly kind of picks away at it. So this is a graphic representation of what that means. And you can imagine there's a tumor up here at the top, and then you give the first strike, which is whether that's surgery to remove all the tumor that you see, or whether it's chemo that, again, can kill all the tumor that you see. But we know that that alone probably will get you to a point of no evidence of disease, NED, but it probably won't get you down to the minimal viable population. You need something else to drop you below that minimal viable population. And whether that's a combination of surgery and chemo, perhaps. We know that, chemo tends to work better when there's less cancer there. But certainly we don't think that moving surgery up front and followed by MAP is all that's going to get you below that minimal viable population, because we've to some degree seen that. But again, this platform might facilitate this, and maybe we need a third strike or a fourth strike or something else to get us down to that point of extinction. So other problems that we need to address in osteosarcoma is that a lot of the molecular data we have on osteosarcoma and the prognoses and anything we know about osteosarcoma's biology is based on those tumor samples, either the teeny tiny ones from the biopsies or tumor samples after exposing the tumors to chemotherapy, or tumors when they've relapsed and we've taken them out, which have likely already been also to some degree exposed to chemo. So we don't have a lot of information on virgin tumors, and we think that information might be helpful in guiding our understanding of osteosarcoma. And if we have a massive amount of tumor, it's essentially limitless of how much testing we could do on those tumors, theoretically. And to this point, as I showed with that first slide of the graphs, nothing we've added to chemotherapy or nothing we've done after those first 10 weeks of chemotherapy has proven to help. Adjusting chemo based on tumor response hasn't accomplished anything. And so there's no, I'll just leave it at that, and then we'll get to some of the concepts later on. So to address these problems in a select patient population, we're proposing a clinical trial where surgery is moved up front. And again, we say select because, for example, I have a patient right now who's 7 years old and will probably need an amputation. That is not a patient that I would necessarily do surgery up front. It takes a while to wrap your head around needing an amputation for a 7-year-old, and let's do everything that amputation if possible. Similarly, if there's a child who's still growing and you could resect the tumor and you'd have to put in a prosthesis that's custom built so that it can grow, that takes time to make. And so that wouldn't be a patient that I would necessarily suggest surgery up front as opposed to waiting 10 weeks as is the current practice. But for a lot of other patients, those 10 weeks of chemo don't really change the surgery dramatically. The tumors don't tend to shrink, and even if they shrink, the surgery is oftentimes very similar. So as long as it's okay with the patient, the family, the surgeon, perhaps moving the surgery up front, we could learn a lot. So we propose upfront surgery followed by the full 29 weeks of chemotherapy. This may improve outcomes by itself. I'll show you some graphs later on that hint at that. But then it'll give us a lot of tumor that we can study. Again, that's probably not going to help the patient who just had the surgery all that much, but it would help future patients with osteosarcoma if we can learn some stuff. And this would kind of be a platform clinical trial that we could then add new agents, new concepts down onto as we learn more on what we study on these tumors. This is kind of a schematic that Scott put together. If a patient comes in, we think it's osteosarcoma, we'd still do a biopsy to confirm. But then, again, after discussion with the family, with the surgeons, with everyone, if we think local control surgery up front would not cause undue harm to the patient, there would be no benefit to waiting until 10 weeks, then local control could happen up front. A whole slew of testing could be done on that tumor. We would do the standard chemotherapy. At some point, if the patient has metastatic disease, thoracotomies could be done. That could be done at the 10-week mark. It could be done at the end of chemo, to be determined. We are also studying whether or not we can detect DNA that comes from the cancer cells or cancer cells floating around in the blood. And so every couple of cycles, we might draw some blood to see if we can monitor the tumor that way. And then we watch the patient, and be it with scans and with circulating tumor DNA or circulating tumor cells. If they do well, they're cured, fantastic. If they recur, again, we could use a similar approach of confirming the biopsy, taking out some of the tumor. Again, second-line therapy is usually ifosfamide based. We could ask the question of ifosfamide versus ifosfamide etoposide. That hasn't actually been asked yet. If we only do surgery on one lung, we might follow the tumor on the other lung, measure that response, and then do surgery on the other lung, and then continue with other therapy if needed. And again, this is just a platform where we could build in adding new drugs, testing new drugs, and new therapies as we learn. And all along the same time, kind of learning things on the side. So what are the potential benefits? So conceptually, we get rid of a lot of the tumor right away. And that, from an evolutionary standpoint, is this maximizes the first strike, getting it down as far as that no evidence of disease, and then we can follow it with second strikes, third strikes. From a community standpoint, we have a lot of tumor that we can analyze in a lot of ways, and that could potentially help predict who will do well and who won't do well for future patients based on what we learned from those tumors. And, we could build in some way of using what we learned from that patient's specific tumor to help guide therapy for that specific patient if they were to relapse or as part of their treatment. If it's a metastatic patient, thoracotomies could be moved earlier too. There's some data suggesting the earlier the thoracotomy, the better. So again, it could also be built in up front. It could be done at week 11 when local control is usually done. Those are all opportunities. And again, we're not saying that moving the surgery is going to radically change things, but at least it gives us a new framework on which we can build and learn more down the line. There's always risks and downsides. The biggest one concerns a lot of people is that if you do surgery up front, systemic therapy that we know is important gets delayed. And if there's complications to the surgery, it might be delayed a lot. So one question we would automatically ask is, how likely is it that chemo will be delayed beyond, say, 2 weeks or 3 weeks, a number that we're comfortable delaying it, but beyond which we are uncomfortable? There's an issue based on especially a prior study, but people who are doing the surgery, some of them don't like this idea of doing the surgery up front because they need time to plan. They need time to, wait to see if the chemo changes things dramatically. So we've actually spoken, each of us, to surgeons we've worked with. Some of them, to be perfectly honest, were not terribly enthusiastic about this concept. I don't know how much of that is they just didn't want to be told what to do. And a clinical trial that I'll show you a little bit about later actually kind of did that. And the part of the reason the trial didn't come out so well. But I think the way it would be a partnership with the surgeons and the families about only doing this in patients where everyone actually feels comfortable, where it could potentially be the best option. That being said, if you're cherry picking the patients that you're treating this way, there is going to be a lot of bias about which patients are getting this done. And that might influence any outcomes. You do lose that period of exposing the tumor to chemo to know if the tumor responds to chemotherapy. Again, we don't know much that changing. I'm sorry. You lose that period to plan the surgery. But again, we would specifically make it so that it's patients where that planning period isn't so important. You don't have any insight onto whether the tumor is responding to the chemo. Again, largely that doesn't change our management in this day and age, and so I'm not sure we're losing much here. There's some theories out there that surgery triggers the development of metastases. Again, it's something that could ultimately be studied. And then what to do with that tissue. There's plenty of people that have plenty of ideas of what to do with that tissue. Again, working collaboratively in a consortium, multiple institutions working together, we can figure that out to maximize the benefits for the whole community, I think. This is a study I was referring to that tried to actually answer this same exact question. So everybody got the same chemo, but some people got surgery immediately and some got it after 10 weeks. It took about 7 years to do this study, and they only ended up getting 100 patients. And again, what was happening with the study is you enroll a patient on the study, and it would be randomly assigned whether they got surgery up front or at 10 weeks. And what ended up happening is whether the patient or the surgeon or the oncologist or anybody didn't like what they got randomly told to do, they would take the patient off study. So it was actually really hard to get patients enrolled on this study. That being said, they got 100 patients. 45 got surgery up front, 55 got 45 got chemo first and then surgery at week 10, 55 got surgery up front. And again, the outcomes were about the same. And here's that Kaplan-Meier. Again, the numbers were too small to really see a statistically significant difference. If anything, the immediate surgery patients did slightly better, but again, statistically, they were equivalent. And again, just event-free survival, so kind of until relapse and overall survival, largely unchanged. But again, that study had difficulty enrolling patients. We hope that by structuring it and getting everybody on board ahead of time, if there is enthusiasm, we might avoid this problem. And ultimately, our question isn't necessarily if moving surgery up front is going to dramatically help outcomes. We hope it does, and we will obviously study that. But we want to use this as a way of learning more about osteosarcoma so that we can help patients later.
Okay, we have a bunch of questions, but Dr. Loeb, do you have some more thoughts to add there?
So I don't know that I have additional thoughts, because Matteo, of course, did a fantastic job describing our ideas. I think that the points I want to emphasize are a couple. So the first is that the main rationale for thinking about changing the order of things that started us down this pathway in the first place was the recognition that all of the mounds of data that have been collected so far about the molecular characteristics of osteosarcomas have all been from tumors that have been exposed to chemotherapy. And the chemotherapy drugs do two things. One is they can damage the DNA of the tumors, and so it can be challenging to know which of the mutations that we see actually existed when the patient was first diagnosed and which are a result of exposure to drugs that damage DNA and cause mutations. And then the second is that the cells that are studied when the tumor is removed after 10 weeks of chemotherapy are the ones that survived the chemotherapy long enough that they were still viable at the time that the tumor was taken out. And the cells that are studied when the patient relapses are derived from the cells that survived all of the chemotherapy. And so in both cases, you're seeing only a subset of all of the cells that were present the day the patient was diagnosed. And so that's a limitation to our current understanding of osteosarcoma biology that we could bypass by having more tissue to study from tumors that haven't been exposed to any therapy at all. And then the second is that one of the limitations in osteosarcoma clinical trials is that every time a trial opens, enrolls patients, closes, wait for results to be determined, and then another study has to be written and open, that means that there's a lot of time in between studies. The skeleton design that Matteo showed sort of in the middle is designed to be one long continuous trial with the potential to have cassettes of different things to try, where it says option 1 and option 2 in the right-hand column, and getting, for example, IRBs to approve those changes as opposed to getting them to approve a whole new trial. Getting them to approve changes is much easier. So if you have a master trial like this set up and 25 centers have the same trial open and approved by their IRBs, and after 3 years it becomes clear that options 1 and 2 aren't any better than either doing nothing or option 1 and option 2 are equivalent, you could amend the trial to add in an option 3 and remove option 1, or whatever seems to be the most reasonable based on our current understanding. And getting IRBs to approve amendments is quick, as opposed to rewriting a trial from the very beginning and having an IRB review the whole trial, which takes much longer. So it builds in efficiency to the way we conduct clinical research in osteosarcoma that we hope will make it easier to test the new ideas that we hope will come from the more in-depth analyses we can do, having more tumor that was untouched by chemotherapy to study in the first place. So I think on top of those, there is the theoretical possibility that the evolutionary biology concepts that Matteo talked about might apply, and it may be that a much more augmented first strike, which would be taking out a big chunk of tumor in the very beginning, might improve survival, but that piece is totally theoretical. The other elements, the more tumor to analyze, the fact that you're looking at an unbiased sample of tumor cells, the efficiencies with regulatory oversight, those things are real benefits, not theoretical. So I think those are the concepts that I wanted to highlight.
Okay, we have a question from Dr. Weiss.
So thank you for having this discussion. I think this is great. I can't think of two better guys to have this talk. Let me do a little devil's advocate from the surgery side. The things that gives me pause is not that I don't like people telling me what to do. I've been married for 20 years, so I'm exceptional at that. The thing that gives me pause is that we know from the Birmingham group at the Royal Orthopedic Hospital that chemotherapy is the surgeon's friend, that the stuff, the hard work that you guys and the patients do before surgery helps me get a better margin. Now, and if we look at the historical data, we know that when all we had was surgery, before we were audacious enough to give kids chemotherapy, that 80 to 90% of those kids had metastatic disease that we never saw. So does having a positive margin have the same sort of impact if you're going to give all the chemo on the back end? I don't know the answer to that. But I do have a little bit of hesitation when I think about a patient who has, for example, a big posterior femur soft tissue mass that's displacing the vessels, that I know my margins are going to be tight in the best of circumstances. Chemotherapy makes me feel a little bit better about that. So what are any of your guys' thoughts about those rambling ideas?
So that's exactly, I think, why Matteo said that the decision of who to enroll on a trial like this, where the question being asked is feasibility of surgery up front, that decision would be made as a team that would include the orthopedic surgeon. So if we had a patient we were sharing together, and we were discussing them at tumor board, and you said, I'm not sure that the margins are going to be very easy to get, that would be somebody that we would not do surgery up front. So the idea isn't to be comprehensive and to enroll every new patient on this study, but rather to enroll patients where the surgeon doesn't have to worry or isn't worried about whether the surgery will go better with after chemotherapy than before. Because the point of the study is not to prove that upfront surgery is better. If that was the question we were asking, then the sort of decision making I just described would introduce so much bias that you would never be able to interpret the results. But if the real question that we're asking is, can we do this safely in a select group of patients and thus yield a bunch of tumor that will give us a better understanding of osteosarcoma biology unclouded by pre-exposure to chemotherapy? That's one where you actually wouldn't get bias from cherry picking who goes on the study.
Yeah, what he said.
When do you perform local control surgery versus amputation? Maybe.
So that is somewhat dependent on the patient. If the question would be, hey, we could do surgery up front and it would be an amputation, but after 10 weeks of chemo, it might be limb salvage surgery. Those aren't necessarily the patients we want for this trial, unless the patient says, you know what, amputation up front. I mean, again, it's a discussion. I don't know a ton of patients where that's the case, where it's like, it's going to change that dramatically with 10 weeks of chemo. But, you know, the ideal patient for this is someone where the surgery would be exactly the same, whether we did it up front or after 10 weeks. If those 10 weeks of chemo would dramatically change the surgery, it's a discussion. You know, if someone would still want amputation after 10 weeks, then okay. I don't necessarily imagine preventing them from getting surgery up front, though, you know, that's kind of a big deal. But generally speaking, those aren't the patients that we're envisioning for this trial. We're envisioning patients where the surgery would be exactly the same, whether it's up front or after 10 weeks, and whether that's amputation, limb salvage, whatever that surgery is, it would be the same regardless of whether it's pre or post chemo.
Would this be only with non-metastatic patients at diagnosis?
We haven't nailed that down necessarily, but this could be with just local patients. I think it would be interesting to have it for all patients, whether they have local or metastatic, and then decide what to do with the metastases at some point.
My thoughts almost are, if you remove the whole tumor at the beginning, maybe it wouldn't spread out to the lungs or the ribs as quickly as if it was left in, where chemo doesn't always work.
Yeah, that's something that could in some way be studied. You know, we know that if you just take the tumor out without giving chemo, again, 80-90% of those do develop metastases. So taking it all out up front doesn't solve that problem. But you can imagine if metastases are caused by tumor cells flicking off of that main tumor, if you take out the main tumor and then give chemo, potentially you are decreasing that number. But again, I don't know that we're going to necessarily answer that with this trial. But again, as Dave mentioned, theoretically, there might be some benefit.
One last question, and then our time is coming to a close here.
I talk too much. I'm sorry.
No, just
That's
fine.
okay.
We needed all the intel. This question is from Joyce Schaefer, who's a clinical registered nurse with Osteosarcoma Institute. She's a nurse navigator. Joyce, your question?
Yes, thank you. My question is, on that clinical trial where you would go with surgical resection, what type of testing are you doing on the tumor? Are you doing the whole genome sequencing, RNA, DNA? And then the second question is, are organoids used at all in the of osteosarcoma?
So we haven't even written the protocol yet. So exactly what testing we're doing is still to be determined. But certainly, whole genome sequencing, creating patient-derived xenografts. If you have a pound of tumor, you can start talking about doing metabolomics. Mm-hmm. You can start doing proteomics. You can do a lot of testing. And so the first step is, one, is this a concept that the community, the surgeons, the oncologists can all get behind? Can we enroll patients? And once we have the tumor, then we can decide with, a lot of smart people what the best use of that tissue is. And then you broke up a little bit. I didn't hear the organoids question.
Just wondering if organoids have been used at all in research at all for osteosarcoma.
I think some people have tried making them. I'm not sure how successful they are. Dave?
Yeah, I think it's a relatively new thing in the field, and I've heard people talk about trying to grow them, but I haven't seen any papers published with them yet.
Thank you very much.
That's an example of that thing that would be easier to accomplish with a paradigm like this, because even in institutions like mine, where the orthopedic favor open biopsies over needle biopsies, the amount of material that comes out at the time of the biopsy is still limiting in terms of what you can do with it after the pathologist is done doing their clearly more important thing of confirming that the patient has osteosarcoma. What's left behind, even if you have an open biopsy, is still limiting. So you have to choose, do I want to do whole genome sequencing? Do I want to do RNA sequencing? Do I want to do something else? If we had 5 pounds of tumor, then the amount of tumor we had wouldn't be limiting anymore. We could do everything that we could afford, which then would mean we would have to raise money to pay for all of those things, but that's a really good problem to have.
That would be a good problem to have. Okay, we're in bonus round now. We're a minute over, but Janet Panic is online now with a question. Janet, if you could do a quick intro of yourself and then ask your question, that'd be great.
Yeah.
Dr. Janet Panic. I'll ask her question since I can't seem to unmute her mic. She says more of an observation than a question, but the first concern for most parents is survival. The potential benefit to the individual patient would be information from the untouched tumor in the event of recurrence. As a parent, that would make a huge impact on my decision, especially if the surgical procedure remained the same.
I think the study that I showed, the one where they randomized patients and they had trouble enrolling patients, showed us that it's probably not worse. The survival is no worse if you do the surgery up front. Again, if we thought it would not be in the patient's best interest to do the surgery up front, that would not be a patient we would enroll in the study. The patient's well-being is the priority. Then what to do with that with that tumor tissue. If there's a way to benefit the patient, great. But even nowadays, if we biopsy a patient's tumor and send it for sequencing, we don't know necessarily what to do with that material and whether doing anything based on the sequencing actually helps that patient. This platform could be a way of studying that more rigorously.
Okay, got it. Okay, any final words? Did you want to talk about a post survey maybe?
Yeah, we drew up a survey, like SurveyMonkey, I think, that we can send out to people. We'd love to hear people's thoughts via the survey. Feel free to add comments if there. I think there's a comment section also, just to kind of get a sense from the community whether or not what the enthusiasm is for such a trial, from people going through this who have gone through this.
Okay, so I think we can make that survey available certainly on MIB Agents website and maybe on an email blast next week. Amanda,
the Facebook group.
Yeah, that'd be great. That'd be great. Amanda and Florencia, who couldn't make it today, between the two of them, they're at, I keep losing the number, around 5,000 osteosarcoma families between their two groups. So I think that would be really useful. Any final words between Dr. Loeb, Dr. Trucco?
Just thank you for giving us the opportunity to talk about these ideas. I think Matteo and I both feel pretty strongly that this is something that shouldn't necessarily be driven just by the oncologists. It should be driven by the entire community, which includes the people who give chemotherapy, the people who do surgery, and the people who are going through this all. And so we're grateful for the opportunity to discuss this with everyone.
Well, speaking for the osteosarcoma community, I think Amanda and I will say thank you guys for what you do and for thinking about osteosarcoma regularly and often as we do, and coming up with great ideas and thoughts on how we can make it better. So thanks for sharing your time with us today. Thank you, Amanda. We hope everybody joins us next week when Dr. Alex Wang of Case Western Reserve University and Rainbow Babies will be with us. He is the 2019 winner of our Outsmarting Osteosarcoma Award of $100,000. He'll be talking about his winning proposal and giving us an update on conditioning the environment for effective therapies for metastatic pulmonary osteosarcoma. And also wanted to remind you that we have this fabulous book. It's a free download on our website, or you can get the actual book, which we actually recommend because it's over 100 pages and kind of hard to download 100 pages. It was written by Elizabeth Vallejo, who's on our MIB Agents team, by Dr. John Healy, who's a board member and on our scientific advisory team, Dr. Trucco on our scientific advisory team and also a board member, Alana Church, who is a pathologist at Dana-Farber and also teaches at Harvard, and really osteosarcoma families everywhere contributed to this. So please download it. If you want us to send it to you, it's $5 shipping and handling, and we hope it helps. So, gosh, that's it, guys. And thanks again for being here. And we'll hopefully see you next week. Please fill out a survey as soon as the meeting is over. There'll be a survey, and then we'll also send you a survey post to get your thoughts on Dr. Loeb and Dr. Trucco's project today. So, thanks everybody, and we'll see you next week.